All right. Hello, everyone. I've got 103, so we're going to go ahead and get started. Welcome to Tribal Innovations for Improving Access to Oral Health Care. This is webinar 2 of 3 in our dental therapy series. So I know you have a lot of choices today for webinars, so I appreciate you choosing us and tuning in today wherever you are at. So thank you again. So this webinar is being funded by the National Indian Health Board Tribal Oral Health Initiative through the Tribes and Tribal Organization Education and Outreach Programs for Dental Health Aide Therapy. For those of you who are not familiar with the Southern Plains Tribal Health Board or the Oklahoma Tribal Epidemiology Center, Southern Plains Tribal Health Board is a nonprofit tribal public health organization established in 1972 to provide a unified voice on tribal public health needs and policy for the 44 federally recognized tribes that are located in the states of Kansas, Oklahoma, and Texas. The Southern Plains Tribal Health Board serves as a liaison between the National Indian Health Board, which some of you know works closely with Congress and the Senate on Indian health policy for Indian country, and the 44 federally recognized tribes, again in Kansas, Oklahoma, and Texas. Our role is to improve tribal public health outcomes for American Indians through establishing partnerships, advocacy, education, data, and research, in addition to training. The Oklahoma Area Tribal Epidemiology Center is a division under the Southern Plains Tribal Health Board. And the OKTEC, as I'll call it hereafter, is one of 12 TECs located across the United States. And they were established in 2005 through core funding received from the Indian Health Service. As a public health program, the OKTEC works with area tribes, state agencies, tribal organizations, academic institutions, other nonprofits, and many other agencies to provide a wide range of services to those we serve. Many of the services we provide consist of training, technical assistance, education, program evaluation, and we also provide internships. The range of services and preventative programs include, but are not limited to, chronic disease prevention, health promotion, survey design and implementation, program evaluation, cultural competency trainings, data analysis, geographic information systems, and grant writing. The OKTEC also assists American Indian Alaska Native health systems and programs by improving access to the highest quality American Indian Alaska Native health data available. The Native Oral Health Network is a program that's supported by the CDC and the Oklahoma Shared Clinical and Translational Resources Grant from the University of Oklahoma Health Sciences Center. And the Native Oral Health Network is housed and administered by the Southern Plains Tribal Health Board. The Native Oral Health Network is a group of oral and public health professionals that center around the fact that oral health is indeed a vital part of overall health and wellness, and we collaborate to improve the oral health of our Native communities through sharing resources and best practices, peer support, and community engagement. Your facilitators for today's webinar are myself, Julie Seward. I am the Oral Health Programs Manager at the Southern Plains Tribal Health Board and manage the Native Oral Health Network. And with me is Alexandria Holt. She works with me through the Native Oral Health Network, and she's a public health specialist also here at the Southern Plains Tribal Health Board. A few housekeeping items. All attendees should be muted. If you're not muted, please make sure that you are. If you would, in an effort to try to facilitate some type of networking during this webinar, please put your name and organization that you're representing in the chat box, just so we can see who all's in the call, and again, to try to facilitate some networking opportunities here. This webinar will be recorded and will be provided to you all later. It'll be posted on our website for on-demand use. Questions will be facilitated through the chat box at the end of the webinar, and also you can feel free at the end of the presentations to, you also can unmute yourself and ask a question as well. Information to obtain the 1 hour of continuing dental education credit will be given out at the end of the webinar. And I can almost assure you that we will have technical difficulties today's webinar. It seems like it happens every time. Again, ask for grace and patience as we work through that. But if there's anything that we can do on your end, please message us, us as in myself, Julie Seward, or Alexandria Holt directly through the chat box, and we will do our best to help you. Okay, so upon completion of this course, we hope that you all as attendees will have a shared understanding of the efforts of Choctaw Nation to improve access to oral health care. Also, to have a shared understanding of the level of patient care that's provided by dental therapists and the importance of culturally competent care in Native communities. Before we get started, I just want to briefly provide some updates on activities to the Native Oral Health Network. Right now we have over 120 members that are representing 8 states, 31 unique areas of expertise that are represented in our network and our group. Some of our projects, it's been a busy year, as it has been for everyone else, I'm sure. But we're increasing our oral health data collection through our tribal BRFIS survey, and this is a 40-question survey. It now consists of 7 oral health questions, which is up from only 2 that we had in our previous versions. Alex is working on finishing up her master's in public health, and through her practicum project, she's taking a closer look at dental visits and dentist to population ratios and how that is affecting oral health outcomes among the Native communities in the Indian Health Service Oklahoma City area, which again encompasses Oklahoma, Kansas, and Texas. We've been working the majority of this year on our peer-reviewed publication, which is titled Oral Health Among Indian Health Service Oklahoma City Area Population, a review of the current data. This report highlights and analyzes the most current oral health data from the 3 oral health GIPRA measures, which are access to dental care, dental sealants, and fluoride applications. In addition to the IHS oral health surveys that are the per age cohort, among other oral health indicators. This has just gone through our peer review panel and will be ready for dissemination early next year. And I will keep everyone up to date on that. And save the date for our last webinar in our dental therapy series. This will take place on January 14th at 1 p.m. Central. And we'll be closing out this series with a panel presentation that will bring a variety of expertise and perspectives on dental therapy. To set the stage for our presenters and our attendees, I want to give a brief high-level overview of oral health in Oklahoma. For those of you that attended our first webinar, this will kind of be a review. We talked a little bit about this on our basics, our dental therapy, the basics webinar. But the oral health care delivery system in Oklahoma, among many other states, needs improvement. So Oklahoma has a 60% critical shortage of dentists, with 65 of Oklahoma's 77 counties federally designated as health provider shortage areas for dental services. As many of you all know, dental school is very expensive. And so we have dental students that are graduating dental school with hundreds of thousands of dollars in student loan debt. And further, the racial and ethnic distribution of the oral health workforce is among the least diverse among health professions, with American Indian, Alaskan Natives largely underrepresented. The IHS Oklahoma City area serves over 1/4, roughly 28% of the total active IHS user population nationally. The IHS Oklahoma City area has historically been underfunded by IHS, consistently in the bottom 25% of all IHS areas, and continues to be one of the 3 areas routinely receiving the lowest funding. American Indian Alaska Natives make up roughly 9% of Oklahoma's population. A significant portion of Oklahoma's population live in poverty and depend on services from Medicaid. Medicaid in Oklahoma only covers emergency extractions for adults. Of course, there's coverage for children, and currently Medicare does not offer an extensive oral health benefit. Oral health coverage and services for pregnant women enrolled in Medicaid in Oklahoma were cut several years ago, along with school-based oral health education services that were administered through the state. And due to restrictive supervision requirements, dental hygienists licensed through the state are not utilized to the full extent of their licensure and education, which creates a barrier for access to preventative services in our communities. According to the Oral Health Report Card that was released this year by the Oklahoma Oral Health Coalition, which is a statewide coalition, when compared to the nation's performance on 13 key oral health indicators, Oklahoma unfortunately scores a D. In addition, according to a report soon to be released by the Native Oral Health Network, which I mentioned earlier, Native Americans in the Oklahoma area are on average 2 to 3 times more likely to suffer from oral diseases compared to their white counterparts. IHS tribal and urban Indian facilities within the state have varying capacities to address the oral health needs in Native communities, in most cases having less resources to treat more disease. So unfortunately, in most cases, within our current system in place, it's the wealthiest and the healthiest that are receiving the most comprehensive dental care. And as you can imagine, the COVID-19 pandemic has exacerbated these issues. So many of the free clinics and events where our indigent will go to get dental care have been canceled and services have scaled back extensively. However, we're seeing tribes innovating and establishing new processes to continue to serve their communities despite current circumstances and barriers. I imagine most of us on this call are familiar with the oral health disparities and inequities that exist. So what we want to do today is focus on the solutions to those inequities and how we can support one another in creating a new narrative and story. With that, today, we are highlighting 2 oral health champions that are contributing to that new narrative. So I'm very excited to introduce our speakers for today's webinar. First up today, we have Dr. Christopher Bailey. Dr. Bailey is the Service Chief and Global Dental Manager for Choctaw Nation Healthcare. Based out of Tallahena, Oklahoma, Dr. Bailey is responsible for Choctaw Nation dental units across Southeast Oklahoma. As an advocate for access to dental care, Dr. Bailey is responsible for developing prevention programs for the people of Choctaw Nation and ensuring they receive the care they need. Dr. Bailey is a 2001 graduate of the University of Oklahoma College of Dentistry and has been with Choctaw Nation since August 2012. Next, we have Rochelle Ross Ferry. She is a practicing dental therapist for the Port Gamble S'Klallam tribe in Washington State and has been there since 2018. She graduated from dental therapy program at the University of Otago in 2006 and completed her preceptorship in Nome, Alaska. She practiced dental therapy in the Bering Strait region, traveling to the rural villages in the region, providing dental care for a week at a time. This year, she received the National Indian Health Board's Heroes in Health Local Impact Award. And with that, I want to introduce Dr. Christopher Bailey.
Lito, everyone. That's hello in Choctaw. I'm proud and I'm excited to talk about this today because I feel like dental therapy could be something that we could really benefit from in Southeast Oklahoma. Can we go to the next slide, please? This is just a little bit about me, and you've already heard from Julie, where I've been and what I've been doing. I'm also a father of 5 kids, 3 teenage daughters, and 2 twin stepsons that keep me jumping all the time. They're 10 years old, and this old man is trying to find energy all the time. I love the outdoors. I think that's why I'm in Southeast Oklahoma. I love mountain climbing, hiking, fishing, gardening, and cooking. If you ever get down my way, I'll make you one of the best smoked beef tenderloins you'll ever eat. It'll melt in your mouth. But most importantly, what I'm talking about today is not myself, but it's me as an advocate for access to dental care because it is sorely needed in Southeast Oklahoma. Next slide, please. Mount Rainier. I did actually climb this in 2017 and got to see the sunrise from above the clouds, which was a very transformational thing in my life. Some ways it let me see things in different lights, and it was probably one of the best trips I've ever had because I spent 10 days going all across that mountain park. Next slide, please. The Choctaw Nation is located in southeastern Oklahoma, as it says here. It's approximately 10.5 counties. It comprises almost 11,000 square miles. Choctaw Nation is one of the largest tribes with 3,000. About 84,000 live in Oklahoma and 41,616 live in Choctaw Nation proper. To be honest with you, I think these numbers are probably a little on the low side just based on how censuses work and how things are reported. And so these numbers are probably actually larger than that. And the Choctaw Nation tribe is growing and it's in dire need of some serious dental health. Next slide, please. This is Choctaw Nation proper. If you took the state of Oklahoma and cut the panhandle off and divided it into a quadrant, we would be the lower quadrant of Oklahoma. That central part of it is very mountainous and very inaccessible region. And so it makes it kind of difficult to go from one point to the next point. And hence why dental therapists could really be a benefit to Choctaw Nation. Can we go to the next slide, please? The service area comprises of 7 dental units. The average distance between clinics is approximately 50 miles. 4 units have 10 or more chairs. Those are McAllister, Durant, Idabel, and Tallahena. The remaining 3 units have 6 chairs or less. And when I say 6 chairs, I mean one clinic has 6, one has 2, and another one basically has 2 chairs. So they're very small clinics. Now, there is some expansion planned in 2021, which I'm excited about. Poto is going to go from 6 chairs to 12 chairs. It's going to be a closed unit that is COVID ready. Vaccine and all, I think pandemics may become something of the future, and Choctaw Nation is trying to do everything they can to mitigate this. And so that unit will be closed with negative ventilation. Additionally, Stigler will go to 5 units. It'll be a closed unit, and it'll also have a negative ventilation. These will probably become the model for our remodels over the future and stuff. We did invest heavily in external suctions and in intraoral isolite suctions, and that seemed to help, and it kept us going even when other tribes were shut down and stuff. We just recently shut down for probably about 2 weeks ago, but we were almost back to full schedule with these instruments in place. And so it has been a true benefit, and it has helped our tribe. Next slide, please. This is Chief Batten, the Choctaw Nation's chief. This is one of his quotes he's always puts on his emails. The true measure of your worth includes all the benefits others have gained from your success. And there's a lot of truth to this, because the more success you find in life, the more others can benefit from it. For me, that success is not personal success. It's changing a mindset in a dental unit to not be a reactionary unit, but to actually be a preventative unit. And dental therapists will play a critical role in this, in achieving this goal. Next slide, please. What I have tried to do, and this started pre-COVID, and it was we were really starting to make some headway, is to focus on prevention by working with multidisciplinary groups such as preventative health, pediatrics, community nursing, obstetrics, diabetes, wellness, and dietary nutrition. We actually began to focus on the whole well-being of the individual and beginning to start at different levels to introduce healthcare or dental care to pregnant moms. I felt that if we could just begin to give them enough information to change the behaviors and habits that have been so prevalent and taught to them over years and years, that maybe we could actually start to influence the prevention. And then we could catch them in the pediatric clinics on their wellness checks, offer more education, give them more supplies, things of that nature, nutrition counseling, and just begin to really start to reshape the minds. I feel like the one key thing that we've never really done is focus on prevention. And to me, that is the bedrock of what it should always be about. We've been trying to apply more fluoride varnish. Our community nurses are going out into the field. I have a certified dental assistant who's preventative specialty. She is doing a lot with the fluoride varnish and doing a lot with helping people. We're trying to inundate health fairs, school events, daycares, and Jones Academy. The Jones Academy is an exciting thing. This is a true innovation of 2020 and COVID, because we had to dial back our services and all that. Jones Academy is a Native American education program in Hawthorne, Oklahoma, serving Native American children from all over. This year, it was only open to residents of Oklahoma. I hope next year it'll be open to more. But we still had, I don't remember the exact number of students, but I think it was somewhere between 60 or 70 students. And what we did in light of COVID is we went out and we screened those patients, because they are a high risk population. We screened them, determined the needs that they had. Was it something that needed to be immediately attended to, or it was something that could wait, such as something like a cleaning? So then what we did is we took the elementary school on one half day, focused the dental unit in Tallahena, and we cleaned all their teeth and even completed some of their treatment. We did that with the high school kids on another day. So what did this mean? In the past, these kids would have spent maybe as much as 5 to 6 days out of school coming into the dental clinics to get their treatment done. We cut it down. We cut the entire thing down to 1 day for most kids, and in some cases as much as 4 days. And so it's this focused efforts like this that kind of gives me the idea where dental therapists could actually be empowered, and where they could really benefit the Choctaw Nation whole. And the one thing about all this prevention should always be the keystone of everything. The reason for that is the long-term benefits, the reduced care and health, the reduced cost in healthcare, excuse me, and just a better overall health and well-being. A healthy mouth. I almost could guarantee you, if someone has a healthy mouth, the rest of them is probably fairly healthy too, even if they have a comorbidity like diabetes or heart disease. Because we all know that a healthy mouth, that bacteria in the mouth, if it's kept in check, your diabetes is more likely that blood sugars is likely to remain stable, and your health is likely to remain more healthy. And so prevention it's critical, not just to the mouth, but it's critical to the whole body. And it begins with the mouth, because that's the first place that it all starts. Next slide, please. I'm going to talk a little bit more about dental therapy and why I think it could be very important to Choctaw Nation. Why I think it's going to become something in the next year that I'm really going to try to push it and see if we can get some change and get some initiative going, because the way I think we could employ it in Choctaw Nation could have a tremendous benefit. We do have some of the highest caries in the nation in Southeast Oklahoma. It's incredibly impoverished. If you can believe it, there are still children that live in dirt floor houses, live in extremely rural areas, that when it rains, they can't go nowhere. It's like stepping back in time almost. Now, Choctaw Nation is investing a lot of money into things and building it up, and we are doing a good job of trying to improve everyday lives of Choctaws. And my mission is to improve everyday dental health lives of Choctaws. And so how can they benefit us? Well, let's go to the next slide. Okay. A dental therapist, and most of you probably already know it, and maybe you don't. I consider it like the PA of dentistry. They can do the simple procedures. They can do prevention. They can do prophies. They can do sealants. They can do restorations. They can do simple extractions. They can do things like that. They can be basically like a frontline warrior in this fight. And so how I could see them being used is making a web over Oklahoma or Southeast Oklahoma with dental therapists in community centers. And so I see a true benefit to the dental therapist, and I'm excited to hear the next presenter talk about her experiences, because I think we all can get a better understanding of what a dental therapist really can do. Next slide, please. Okay, Choctaw Nation, we have 16 dentists, 12 hygienists, and approximately 10 expanded function assistants with a Profi license. If you look at how many patients we have per dentist, that 4,700 per dentist is probably a significantly higher number than that. It's not the 41,000 people that we treat. It's the people that come from all over. That part of that, out of that 80,000 and out of that 223,000, it's those people that come. We have patients I have patients in Tallahassee that come all the way from Denver, Colorado, Houston, Texas, from Louisiana, from Southeast Missouri, Arkansas, as far as like Little Rock and places like that. People will travel because what they can do is they come to the hospital and then get all their services done. So that burden of the system, is even increased more just because of the volume of the number of patients that we have. If we had dental therapists, we could start to make that number a more manageable number, one that might be more equivalent to what IHS recommends we have as a standard for number of patients per dentist. And the geography of Southeast Oklahoma, it's one of the most beautiful places in Oklahoma. And I'm sorry for the other parts of Oklahoma. I'm just partial to it. In the fall, like we just had, the leaf change is one of the most beautiful things when you drive through those mountains. And I have the privilege of every morning driving through there and seeing it, and every evening coming home from it. In the wintertime, the mountains can get this frost up on the tops of them because the clouds get so low that they freeze, and the tree looks like like a glistening winter wonderland. It's very beautiful, but that's about where it ends. It becomes quite a quagmire of sorts because it's hard to get from places, and people have limited transportation in Southeast Oklahoma in some cases, and so to even get to one of our clinics can be a challenge. And there's a lack of paved roads. It does make it hard to travel in the northern and central parts of Choctaw Nation. An example of that would be, we have an endodontist and a pedodontist in Durant. If you live in Poto and you need one of those services, you're probably going to have to drive 5 to 6 hours just to get to that clinic. And so that right there, you start to see this geography impacting how we can deliver services and how we can do things. And this is where I do think dental therapists can fit into it, because I believe that in the community centers, which are gathering places for the people and can have significant turnouts and all that, if you had a little mobile clinic inside that community center, you could actually start to create a nice little preventative chain. You could begin to examine people and clean their teeth and do things preventative and restorative and stuff like that, that now you've taken that burden off the clinics and they can focus on the bigger and harder procedures. And so it's a win-win all the way around. Services that might be referred out may not have to be referred out because the dentists actually have time to do things while the dental therapists are helping us get to that point. And on the other point of that, I feel like the more we can get out into the community with the dental therapists in the community centers, all that, the more we can preach the message of prevention. And the more we can make behavior change, because behavior change is the critical part of this whole puzzle. Southeast Oklahoma, and it's not everyone, but there's a large part of that population that has the mentality that my parents had dentures, their parents had dentures, I'm going to have dentures, my kids are going to have dentures, and their kids are going to have dentures. It's a hereditary thing. It's not a hereditary thing. It is a preventable thing. It's just, we need to educate and we need to better make people understand how to take care of their teeth, how to brush twice a day, how to floss, how to rinse that mouth out after you drink one of those sugary drinks. It's just there's a lot of things that we could do different, but we have to get out and we have to be able to get the message out. We can't sit in the four walls of our clinics and expect that we're going to create some great change out in the nation. And so that's where dental therapists, to me, are going to play a critical part in this puzzle. Next slide, please. Okay, so why dental therapists for Choctaw Nation? I apologize because I had a few more bullets on here this is version 1. Version 2, I think I sent, I'm sorry, Julie, I think I sent you the wrong version, but I can still talk to it. The expansion of preventative services leading to early intervention. A University of Washington study showed that early intervention showed fewer extractions and kids losing fewer incisors early on like they normally do. It also benefits these kids. If we can get to children, and I'm talking mainly about children now, but there's also adult therapy that we can benefit too. But in children, if we can catch early on when things are starting, that means fewer trips to the ER, means fewer trips to surgery, means less general anesthesia. It means probably a happier life. It probably means a better functioning mouth, aesthetically better, because we know when we start to lose teeth, when we lose teeth early, bad things start to happen. And that's one thing I am really an advocate. I want to change this mentality, and I want to begin to shift the mindset that if we do these preventative things, we can raise kids that are caries free. We can do things different. And we've really all got to work together to make the message known. Dental therapists can be behavioral advocates. They can change that mentality that my parents had dentures or my kids are going to have dentures and all that. There's nothing sadder to me, and I've seen this more times in the last 8 years that I worked for Choctaw Nation. A 20 or 25-year-old coming in with bombed out teeth, having to go to an oral surgeon, get everything extracted, and go into dentures. That is no quality of life, and that is definitely going to have long-term effects on their overall health. Dental therapists in this regard, I think, could begin this process of educating people and getting them changing that mentality and just creating a greater environment so that we can get care in these very remote, impoverished areas. It's difficult for even like the dentists in private practice and all that. You don't see them in the smaller little towns and stuff. Or if you do, they're not doing that much. It's not, and I'm not faulting them for that. It's just a fact of the nature. It's a very impoverished thing. It's $50 and pull a tooth, or spend some money and do that. And most people are going to take that $50 option. That $50 option should be taken off the table, and those people should learn and be educated and just taught how to really just to take care of their teeth and everything. Dental therapists also kind of take the burden off the dental hygienist. And what do I mean by that? Well, if the dental therapist can do the prophies and things of that nature, those hygienists can focus on those diabetic patients that have severe periodontal or have periodontal disease that, if not kept in check, wreaks havoc on the rest of their body because of the infections that go along with it. And so those hygienists can be more effectively utilized. And I'm making a push, and I've done it in the last couple of cycles, of adding more hygienists. I'm going to really push in the next year that we start to begin to look at dental therapists and getting things changed to where we can get to that point. To me, it's almost like Southeast Oklahoma is not quite like Alaska, because I've been to Alaska and I know how remote those villages are and how you have to pontoon plane into places and things of that nature. And I can see the critical role of the dental therapists in those places, and got to experience talking to some of the dentists that were over them. And I think a model like they use, we could employ. You could do a lot of things different with a dental therapist than you can just do with what our standard teams are built around. Next slide, please. I do have concerns because all my research does prove, there is some pushback from the professional organizations, and there's pushback from some of the professional professions in the state organizations about dental therapists. I think we could overcome this, though. I think we could achieve the first two things, patient's acceptance and that first bullet point, with dental therapists if we brought them into our clinics, let them work for 90 days in there, and let us see what their skills are like and where we can get a confidence level. And then we can assign them out into the field in an area where those patients have almost no access to dental care. I still see patients that haven't been to a dentist 20, 25 years into their life. we need to really do something different in Oklahoma. And this is something I feel like we could make a significant change in the way we do things. And, you know, I think there'll be some pushback from some of even the dentists that I'm over. But I think once they begin to see what we can do and what's happening and the health of what the patients we are treating or coming into our clinics are looking like, then I really feel like everyone will be on board with it. I think it is truly a win-win situation. I think the more prevention you can perform out in the field, the more cleanings, routine cleanings and things of that nature that patients maybe only get once a year, now get twice a year or get more, you can start to overall shape the health of Choctaw Nation proper. And, you know, there's concerns about starting costs. You know, is it going to cost that much for the tribes to set up these mobile units into the community centers? I think if I can prove to them, and I believe that I can, and show them what benefits we can gain from dental therapists, they will be more than willing to go down this path. And I will continue, because one thing you'll learn about me over time is I'm very persistent and I'm very patient. I have an immense amount of patience. My father taught that to me. I think that's the whole thing about fishing. It's patience. But to me, it's patience about doing what's right and to find ways that we can make the health of Southeast Oklahoma better. The other part is just recruiting to that area. The one thing I could see how to get around this, though, is you do take people from the areas that they're going to be in and train those individuals, and so that there is a familiarity with them. And then you get them out into the communities where they grew up and where they lived. And I think you'll start to see a shift in just the behavior and the mentality of what people think and how they believe. It's not rocket science, but it does seem like it's just a simple way to actually achieve something very dynamic. Next slide, please. Okay, my concluding thoughts are just the need for access to dental care in Southeast Oklahoma, as in many areas, demands we think outside the box and find creative solutions for the problem. Clearly, what we have been doing has not been working. We need to have interdisciplinary collaboration to create avenues of prevention as one such way. Dental therapists may be the key solution to that problem and provide a bridge to the prevention and access to care, changing the minds and beliefs, the habits of tribal members, and the ultimate solution. And the ultimate solution, we must always be advocates for those we serve. I just want to say that it's been a privilege that I've got to speak to you all. I truly have spent a lot of time on the thinking about dental therapists and if it was going to be a right thing for Choctaw Nation. I feel like what you could gain if you had therapists in community centers and you did a web over Southeast Oklahoma, you could create this dynamic network where people would have access to care, where they could get simple services done, where they could get restorative, where they could actually begin to change their minds about their teeth. And it would, and the end all would be a very healthy nation. And that is my ultimate goal. I told one of my assistants, I said, if I could take 100 kids that were going to get cavities or decay or caries, and I could save 10 of them from getting that, I would call that a huge win. That it would be even a huger win. And it's a goal of mine to see that number drop to the reverse of that, where 90 kids have no decay and 10 maybe have decay. And that decay is caught soon and it's ended, and they go on with a very healthy mouth and a very healthy lifestyle. I appreciate you listening to me, and I'm very excited about what this could lead to. Thank you. Yakoke.
Thank you so much, Dr. Bailey, for that wonderful presentation and all your insights and the work that you are doing within Choctaw Nation. We are going to jump right into our next presenter, which is Miss Roz Ferry. So, Roz.
Hi, good morning, everybody. Happy holidays, and I hope everybody's healthy. So my name is Rochelle Ferry. Our Siwak is my Eskimo name, my Nupek name. I'm a Nupek. I was born and raised in Unalakleet, Alaska. I'm sure most of you don't know where that is. It's a small coastal village along the Bering Sea. There are about 700, there might be more now, people in my village. I have two daughters, Kaylin. She is 18. She thinks dentistry is disgusting, so she will not follow in mama's footsteps. My 13-year-old daughter, Danielle, has been exposed to the dental clinics her whole entire life, has, been around it. So she thinks what I do is awesome. And she wants to become a dental therapist. So I'm kind of proud. So growing up, we had one dentist in our village, and I don't believe he actually even moved there until I was in high school. And we were extremely lucky to have a dentist living in our village. And it was actually fishing that drew him to Unalakleet. So I decided at a really young age that I wanted to be in the dental field. I was 16 years old when I lost my front tooth. We were playing Red Rover at a church event. And it was such a horrible experience for a girl at 16 years old. I lost my front tooth, and it left me with a serious lack of confidence. And I became one of those girls that covered my mouth when I laughed or spoke. I didn't like the flipper I wore while waiting for the healing process to conclude and the bridge prep. And there were times where we'd be in school and some of my friends would do things like make me laugh so they could snatch my flipper out of my mouth and run down the hallway with it, and I got to the point where I went down to my mom's classroom. She was a school teacher, and I told her, I'm just going to be one of those people that lives on Front Street that doesn't have front teeth, and it's like, I'm going to quit school because it was such a horrible experience. And the very next day I was on a plane to go and get, my bridge prep started. My mom didn't want that for me. So this was a turning point in my life. I started to notice that there were a lot of girls and women who would do the same thing, because they had decay on their front teeth, they would cover their mouth when they spoke or laughed. And I was humiliated. I decided at that time to pursue a career in the dental field. I wanted to prevent others from feeling the way I did. Decay has an obvious impact on someone's future and their entire life, and I wanted to help. I didn't want people to feel the way I felt. So at this time, I had also completed most of my graduation requirements. So I had to fill most of my day with OJT, which is on-the-job training. So I worked part-time at the dental clinic as a dental assistant until I left home to attend a college. I couldn't, and my family couldn't afford to send me to dental school. So I was doing the next best thing that I could do. And I went, 2001, I completed the dental assisting program at the University of Alaska Fairbanks. And I began working for the Tanana Chiefs Conference. So I spent the next few years traveling around interior Alaska as an expanded functions dental assistant. I really enjoyed my job, but I didn't feel like I was doing enough. I wanted to be more involved in patient care. In 2004, I began studying at the University of Otago, and that was probably the hardest I've ever studied. I literally spent 2 years in a lab or in front of my computer studying. My then husband and my daughter would leave to explore the island on the weekends, allowing me time to concentrate on my classes. And I graduated in 2006 from the dental therapy program. And I went back to Alaska and I completed my preceptorship under Dr. Kelso at the Norton Sound Health Corporation. And that's kind of funny because I got off the plane in Anchorage and I was so excited to see my family, and my cell phone rings and I'm like, oh, it's Dr. Kelso. So he was calling to congratulate me and also to let me know that my name was being added to the list of people being sued by the American Dental Association for practicing dental therapy. I was like, I haven't even touched anybody yet. He's like, well, you've got the title and they know you're coming back. So they added your name to the list of people. So that was kind of intimidating. So I completed my preceptorship under Dr. Kelso at the Norton Sound Health Corporation. And we traveled to 15 villages along the Bering Sea, providing dental care. We slept and worked in clinics and schools, shops, basically anywhere in a village that you could find to take up that space for a week. It was such a good experience to have the opportunity to travel around Alaska. I met relatives I never knew I had. In fact, when I moved to St. Michael, and I'll talk a little bit more about this later, I brought my grandmother with me because she had history in that village. And if the elders respect you and will come and see you and feel safe with you, then everybody kind of follows in suit. And my grandmother, even though she wasn't from St. Michael, she was an elder known in St. Michael. So we spent 2 weeks on Diomede Island, and that's one of the most remote places on Earth. So here is real quickly is a slide of some of my classmates at the University of Otago. You can go to the next slide. And then there's Dr. Kelso, and we were on our way to Diomede. And so we were waiting for our little plane to come and pick us up. Next slide. And this is the entire village. This is an island in the middle of the Bering Sea, and this is the entire village right there. Next slide. And we traveled, it's a small village of 70 people in the middle of the Bering Sea, and it's 2 miles from the Russian border. We landed on the ocean ice, just a mile from the border between Russia and the United States. We loaded our gear onto a dog sled, and they pulled it by snow machine to the village. And we actually walked along the pressure ridges to the village, and we set up our clinic in the wood shop of the school and slept in the library. Next slide. So there's Dr. Kelso, and we had forgotten the stand, some part for this X-ray unit here. So he actually bolted it to like a weight bench type of deal that was in the gym. I mean, he didn't even ask. He just went and grabbed it and drilled some holes in it, and our X-ray unit was standing up. Next slide. And this is where we worked. We had everything that we brought. That's what we worked with, and it was whatever we could fit into one single plane. So it was a really compact trip. Next slide. And this little boy's name is Ethan. He's an adult now, and the person in this chair is his mother. And my dental assistant, she had to kind of go, between two chairs and sterilization. And so there were times where I was working alone. Dental therapists are trained to work alone. So I did that quite a bit. And because he was there, I had seen him previous. He was sitting there, and you got to keep him occupied at this age. So I had him sit down and put some gloves on, and he really felt like he was contributing to the care of his mother. It was a lot of fun. He's one kid that I won't forget, because he grew up loving dentistry because of these sort of experiences right here. He got to be involved in his mom's care, and that was awesome to him. Next slide. And that's, graduation, the University of Otago, and down there in the corner is my little daughter. She was 4 years old then. It was a really good experience for her as well. Next slide. And then there we are. There's my dental assistant. And again, we're in the Diomede clinic and treating patients. There's really no barrier, nothing between the two rooms there. You can see Dr. Kelso working off in the corner. Next slide. And then these are a little out of order, but this is my graduating class, and we came from all parts of the world. It was a good experience. Next slide. So I did, as a dental therapist, we do a lot of outreach and a lot of presentations. And this was for one of the health fairs in Nome. We put up a table and spent 2 days there talking about dentistry and, dental therapy. And our chosen topic then was tooth discoloration. Next slide. So In 2007, I moved to St. Michael, and I became the main provider for St. Michael and Stebbins. Prior, they'd had a dentist travel to the village two or three times a year. So that's all the dental treatment that these people, most of them, received. It was, a dentist coming into the village for a week at a time, 2 or 3 times a year, and that was it. The rest of it, if they had a toothache, they had to be seen at the clinic and then catch a plane and go to Nome or to Unalakleet for treatment. And so there was no consistency in their dental care. I turned a clinic exam room into a dental clinic and provided the majority of care out of the St. Michael Clinic. And I traveled 12 miles to Stebbins 1 month a week. And this was the clinic in Stebbins. This one was also an exam room that I kind of added stuff to, and I was able to get a dental chair out there. I don't think I let anybody know I was taking it either. I just took a dental chair because we needed something permanent in Stebbins. So that was probably around the time that this picture was taken. This was probably the most exhausting point in my life. I went through a lot of emotional trauma. Sorry, I get emotional thinking about it. For the first few months, I spent the majority of my time pulling teeth, which is why education is so important. I had a mom come to me one day and tell me that her baby's front teeth, his first 4 front teeth were in, and she wanted to know when we were going to take them out. And it just blew my mind that this was so common, that this happened so often, that children, as soon as their teeth were coming in, they were decaying. And so it was unheard of for children in these villages to have their front 4 teeth or not to have silver caps. And so my mind was blown that was the question being presented to me at that time. I almost became numb to the emotional stress caused by papoosing babies to extract their teeth. It became so normal that once, what had made me cry before, I could walk out of the room and go and eat lunch, and that was shocking to me, that it caused me so much emotional trauma in the beginning, papoosing a baby, holding their head down, getting them numb and taking their front teeth out. It was so emotionally traumatizing that when I realized that I could do it all morning long and then go and eat lunch and not think twice about it, I was disgusted. I was really, really hurt that was the normal. So I spent a lot of time talking about the progression of decay. I spent a lot of time talking to moms. Moms, to me, were the most important group to speak with at that point. So I spent a lot of time talking to about the progression of decay. And after a year or so, I started to notice a change, and there were little ones running around with their front teeth, and they're so cute when they've got those front teeth. It's, and it was something that I hadn't seen in a while, living out there in St. Michael and Stebbins. So, I provided most of the care, the majority of the care. I did all the exams on the children. We just, class by class, we'd call them over and we'd get all their exams done. And then a dentist would visit periodically to provide care I wasn't able to provide. They'd also go over the treatment plans I had for these 60, 70 kids. We'd pull all the charts out and we'd be discussing, these kids need to go to the pediatric dentist in Anchorage. We can get these kids done. And then I'll come back out here. The dentist would come back out and he'd crown these teeth. And so it was busy. It was a very busy time in my life. In 2018, I was given the opportunity to work for the Port Gamble Squalum tribe. And that was a new experience for myself, as well as the entire dental clinic. Dr. Block had only heard of dental therapy. And so he was experiencing this huge learning curve as well. It wasn't a difficult position to introduce into the dental clinic. I think the impact was mostly felt by the front desk staff, particularly with scheduling. It took some time for the front desk staff to adjust to a schedule for someone who wasn't able to perform all procedures. I had denture patients, a couple of times, and I'm like, no, I don't do dentures or, extraction of wisdom teeth. And so it was a little bit of a jumble and a little, we had to navigate that. But it was a little bit of a change for the dental clinic. Because I had taken 2 years off out of my career, I had to go through my 400 hours of preceptorship again. So I did that under Dr. Block. And we focused on introducing the DHAT program to the tribe. My position was unheard of, and there was a lot of questions from tribal members about what I do. At that time, I also took over the existing outreach programs and created new ones where I thought the need was not being met. Education and prevention were the major areas I focused on. And we now have several programs. We have an early learning center, and I spend 2 days in the classroom every 6 months doing limited exams. And by limited, I mean mirror and explorer only. And the focus is identifying visible decay so that we can get the kiddos in for treatment before they feel pain, as well as to prevent any emergency situations with abscesses. So I visit the ELCs for Port Gamble, S'Klallam tribe, as well as the Suquamish tribe. And after these exams, we apply fluoride to the children's teeth. And it works really well considering the fact that all of the teachers in these classrooms are also brushing the children's teeth every day. So that makes a huge difference in the amount of decay that we see. The tribe also has an after-school program for school-age students, and our focus is on dental education. This age group is hands-on and visually stimulated, so we do a lot of hands-on learning. We do a lot of disclosing with disclosing tablets. They love that. It's an awful mess, but it's worth it. We also do, we do a lot of oral hygiene. We do roundtable discussions with typodonts, things that they can hold and pass around, as well as photos. And this is important because at this age group, I'm their first contact when they come into the clinic. So I do all the school-age children's exams and their prophies. That frees up the hygienist to concentrate on adults. So we also have a mothers group. We meet with new and expecting mothers at the Mother and Children's building on the reservation. We provide oral hygiene instruction, and we do limited exams there as well. We have a Nomad, the portable X-ray unit. So we make use of that when we can. So we do those for mom and baby, check both their teeth. And it's second nature to us as dental professionals. We don't think about the importance of dental care or decay transmission because we know it. So it at first it sounds kind of silly having to, start with you brush your teeth twice a day, but it's not second nature to everyone. So we also provide all the dental supplies that they'll need, the toothbrushes, the floss, the paste, anything that they need to keep their mouths as well as their babies' mouths clean. We have an elders program, and this is probably my favorite group, and I don't know if I should say that because I don't know if we're allowed to have favorites, but this is my favorite. We meet with the elders, not only in the center, but we also spend time with them in their homes. We often end up in the gardens. Grandmas love, love, love their gardens, and they're so proud to show them off. So our goal with the elders program is to develop trust and familiarity. I want to be a familiar face, someone that elders build a relationship with, someone they trust to listen to their concerns and fears. So most everybody knows that dentistry was not as delicate as it is now. And there are a lot of elders who went through a lot of trauma. They talk here on the reservation about the trailer at the top of the hill where you went in and it was dark and dingy and, it wasn't the best experience. And so they are a really, really stubborn, really, really hard group of people to change their minds. So we began doing the home visits, and there was one elder in particular, really wanted to get into the clinic for fillings and a good cleaning. After a few home visits, we'd spend some time talking about her garden, talking about her grandchildren. The elders love talking about their grandchildren. So we'd spend a lot of time talking about their babies and their grandbabies. So after a few home visits with her, she opened up to us and explained that she doesn't like going to the dental clinic or anywhere because of her weight. She couldn't walk well and didn't want to sit in the waiting room. So knowing this, and I wouldn't have known this if I wasn't doing this outreach, if I wasn't going to her, so I was able to discuss options we had as far as getting her into the clinic without having her sit in the waiting room or check in at the front desk. I coordinated with my assistant and the front desk staff so that this particular elder, we were able to bring her in the back door. And she was so thankful that we were able to do that for her. She later said that she'd been living with a toothache, but would not tell anyone because she was afraid. She was afraid that they were going to make her go to the dental clinic. So she got her work done, and I really cannot wait to check on her and visit with her in her garden when we're able to do so again. This has been a really weird couple of months. So the goal of any dental provider is to provide the highest quality treatment to our patients. And it's important to adapt individual treatment plans and outreach to fit the culture of the population you're providing care to. For example, in Alaska, in my culture, in my region, my people, we have a tendency to chew up food for our babies and then feed it to them. I did it for my kids. My mother did it for me. I probably won't have my grandchildren be doing this, but that's part of my culture. We talk in Alaska, we talked in depth about moms at the maternity center and in the villages about chewing food for their baby and how that can pass on the bacteria that causes the decay. And so their children are predisposed to the decay at a really young age. That conversation would not make sense here at the Port Gamble S'Klallam tribe. These members, that's not something that they do. It's not part of their culture. So it would make no sense for me to have that conversation here. So knowing your culture, knowing the people that you're providing care to is really important. It makes a big difference, especially in young children and elders. If the provider is someone who is consistent, someone they see every time they come in the clinic, as well as someone they can relate to. I'm Native, I'm half Native, so I look a lot like my patients and they can relate to me on a visual sense. A lot of times new patients will ask, what tribe I'm from or where I'm from, or, and it's a great conversation starter, a great icebreaker, especially with the elders who, they're like, oh, I've been to Alaska. Nobody's really been to my area because we're so far north. A lot of the elders, a lot of the people that live in this area, they go to the Southeast. So, I gotta learn a little bit of the Southeast so that during that point I can have something to talk about, because that's the rainforest. I'm from where it's snowy 9 months out of the year. So dental therapy has been extremely rewarding for me, not just me, but for a lot of the people in the villages. When I left St. Michael, I left with a foster daughter. She is now a health aide back in St. Michael. So, it was rewarding in that sense too. A great example, and to be honest, the reason that I chose this career path kind of revolves around a story about a girl. She had just moved from Washington, or to Washington from Canada, and was very withdrawn. She didn't want to be here. She didn't want to interact with me or any of the staff. You could tell that she did not want to do this. We did her exam, and she was in very poor condition dentally. I spoke with the family caring for her about her treatment needs, and I could see that while I was talking to the girl would pull her sleeve over her hand and place her sleeve-covered hand over her mouth when she talked, like I did when I was 16, the exact same thing I did when I was 16. So I asked her if she did that because her teeth hurt, or if it was the way that they looked, and she didn't respond. She just shrugged her shoulders. So I left the operatory and I turned with my phone to show her a picture of myself at 16 without my front tooth. I really thought about sharing that picture with y'all, but I'm not ready. So it's a horrible picture, but I keep it for times just like this example. I could see a change in her posture when she saw the picture. She, kind of was like, whoa, because she'd seen me talking, and I have a really nice bridge. So I explained to her that what we would do to fix her smile. And at her next appointment, I fixed her front teeth. And then I handed her the mirror, and she cried. She had tears coming down her face. And I cried because I knew how she felt. So she came into every one of her appointments, and by the end of her treatment, she was walking around with a big smile on her face, no sleeves covering her mouth. So that is one example of what makes my career so special. All my patients are important, but those I can relate to, like the girl I just described, those are the patients that make my work rewarding. And so if you want to go to the next slide, I can kind of tell you about that. It's that's my daughter. She's one of my little patients, and I've done all of her treatment from the time she was, since she got her first tooth to now. Next slide. And this is one of the classes that I visited when I was in Alaska. This is the Head Start. And we'd go in and take their x-rays, with the little handheld Nomad. And we did their toothbrushing and put the fluoride on their teeth and did a little OHI. Next slide. And that again is my graduating class while we were in class actually at the University of Otago. Next slide. There's me holding a seal. That was a really fun experience. This was taken just outside of St. Michael where I was living. We had gone out with my cousin seal hunting, and we didn't catch this mama. We let them go, but before we did, I had to hold the baby. Next slide. Oh, that's it. The end.
Thank you so much. Thank you so much. Thanks for sharing your story, Roz, and thank you for your heart and dedication to what you're doing. And that goes for you and Dr. Bailey as well. Wonderful presentations, wonderful examples of what the work that's happening in Native communities. And so I know it takes a lot to share those stories and kind of get emotional and kind of revisit some of that. So again, thank you so much for that. I really, really appreciate it. Okay, so let's open this up for questions. Feel free to put your questions into the chat box. Also, if you'd like to just unmute yourself and ask a question or make a comment to the presenters or anyone, please feel free to do so. We've got a few minutes left for Q&A. Anyone have any questions, feel free to unmute. If you do not feel comfortable unmuting, go ahead and put your question in the chat box. While we're waiting on those questions to come through, I want to ask, and this is to both of our presenters. So what do you feel is the biggest misconception of dental therapy, the practice of dental therapy? Do you have anything in kind of your perspective areas of work? What are some of the misconceptions that you all have come across?
I feel it's the misconception that it's somehow impacting the business of other dentists in some ways. And the reality of that is these patients don't go to dentists, and they certainly aren't going to go to somewhere where they're going to have to pay for dental services. And to me, it's a fundamental issue that everyone has a right to deserve dental care and health care. And so I think it's just a misperception of the services. They're trained. It's not like they're just walking off the street and starting to do something. They actually receive a very good education by what I have found. And I feel that in places like Southeast Oklahoma, they will be a vital part of a program.
I am muted. Okay. Thank you. Ross, do you have anything to add to that?
Well, to add on to that, there is that misconception that, we are untrained. That is completely, I have never studied harder in my life. I have never been under so much stress in my life as when I went to school for dental therapy, because they jam pack a lot to learn in 2 years. It was overwhelming in the beginning. For the first year, it was really overwhelming because I had to develop a real routine in order to make every day count, and every day mattered as far as, my schooling went. If people knew how much time that I spent behind a computer, or any dental therapist in school spends behind a computer or in the lab, they definitely, their opinion would change. It's a lot. It was a lot.
I want to expand on that because I have a dental assistant who's expanded function. I think she'd be an outstanding dental therapist. She can do restorative procedures and all that. And some of her restorations are some of the finest I've seen. She's very meticulous. She does good work. And so if she can do that, I don't see any reason why she couldn't prep a tooth. She could probably do an excellent job with that and restore it and do other simple things, simple procedures and stuff like that. I think it's just a misconception, and it's based out of fear. I think most things that we do not want to, that we push back against, are because they're fear-based, because we don't have an understanding of what's actually occurring or what's going on. And Suzanne, who I just mentioned, like I said, her restorative is as good as anyone that I've ever seen. So that's a dentist, that's dentists and other dental expanded function dental assistants. So.
Thank you, Dr. Bailey. Thank you, Ross, for that. I just want to share some praises for you both. Awesome presentations. Thank you for sharing and your dedication to improving oral health and quality of life for so many. Great presentations.
Thank you.
And then we've got a question from Candace. Hey, Candace. Do DHATs have a trend to stay in rural areas, or do they gravitate toward bigger cities as their career progresses? Great question.
So dental therapy was created, and it started in Alaska simply to get more providers out there. Not everybody, there's not a whole lot of dentists that want to live in a village, and it's, some of these villages are like St. Michael's, 200 people, when they can make the same amount of money living in a city. So the idea was to take people from these villages to provide care to their villages. And the majority of them up there stayed. I left because my life situation changed and I was ready to do something else. But a lot of people, they are comfortable. A lot of dental therapists are comfortable and want to stay in their communities. And this gives them that opportunity, because a lot of people end up having to leave their hometowns because there's not enough opportunity. So this provides for a career advancement for, 1, 2, 3 people in their communities.
Yeah, and I agree with that, because we're seeing a trend in Southeast Oklahoma of people coming back to where they grew up. I get more dental hygienists applying for jobs that moved off, but now they're coming back because it is a nice place to live. It's quiet, it's peaceful, and so I would find it hard to see them training them and then them moving off. I think for the most part, people still have some pretty fairly cultural values that they hold dear to, and they believe in faith and family and things of that nature, so that I don't see the trend of them moving off.
Okay, thank you for that question, Candace. Okay, we've got another question from Janelle. Thank you so much for both presentations. It is so inspiring to hear of the paths you both are creating. I currently live in Santa Fe, New Mexico, and would like to start work in the reservations, but not sure how I can find our way in. I'm a dental hygienist who would like to help offer treatment that I can, even if it's just OHI, oral health instructions and general information, but just wondering how you began and worked your way into the villages.
Well, for me, I grew up down here, and I went off to Oklahoma City and Norman and to train and all that, and worked up there for about 6 years and got tired of it and moved back home. And so mine came through actually some professors that I worked with or studied under at the University of Oklahoma were all working for Choctaw Nation down in Tallahena, and I got approached to come down here and take a position, and I drove down and loved it and haven't looked back since.
I'm from the village, so I had my in. I did leave to go to school. There wasn't a program in my hometown that would allow me to further my education. I couldn't do that without leaving, and so I left with the full intention of always going home. I didn't get the opportunity to go back to Unalakleet per se, but I did get the opportunity to go to St. Michael, where my grandma had a large amount of family ties. And so, it was really smooth and just almost natural for me to go that route. When I moved here, they were looking for a dental therapist willing to move out here to bring the program to the S'Klallam tribe. And at that point in time, there was still a very limited dental therapy pool. And so at that point, I was not practicing. I took, 2 years off to concentrate on my children, and I was ready to go back into dental therapy. So that's how I ended up here in Washington.
And I would suggest just to go to ihs.gov and look for the career paths and see what's available in that region.
Thank you, guys. And I would also add to that, I think developing relationships is first and foremost in any community that you're working in. So there is a lot of time and commitment and patience that I feel like is involved in that, to be able to go into a specific community and provide oral health instructions or care or whatever that is, because I feel like you really need to have a good solid understanding of the community that you're in and that you're working with. A lot to what Ross was kind of talking about, the cultural nuances and those things. I think it's very important to have that relationship established. Okay, and let's see, Dr. Miller. Hi, Dr. Miller. Wonderful presentation. I really appreciate your passion for patient care and oral health. And Kim Perry, thank you again for the presentations. Where do you envision the dental therapy needed being trained?
For me, I think it would be like someplace like the university, like the University of Minnesota, places like that have established programs. Eventually, it would be nice to develop an educational program within Choctaw Nation where we could do that, because the Choctaw Nation does invest a lot of money in education. And certainly they will, pay for school for natives to go. So it's, I think there's several avenues of where that could, how that could happen.
Okay, thank you. Great question. And then Bonnie, hey Bonnie, and she just made a statement that I believe New Mexico has passed dental therapy in their law, and I do believe that's accurate for the question earlier. Okay, any other questions or comments?
I just want to tell Roz that was fantastic.
Really was great. Great stories. Okay. If we do not have any other questions, I've got 2:25, so let's wrap up here with just a few other items. Let's see if I can. Okay. All right, so in closing, here's kind of the call to action here from what we heard today, from beginning to end. We want to highlight the work that all of you are doing, because I know we've got all of the attendees here. There's some I recognize from past webinars and some new names, and I know you all are doing great work. And so we want to provide more opportunities for networking and collaboration, and also to, like I said, to highlight the work that you're doing. So sign up to become a Native Oral Health Network member. Alex is going to put that link in the chat box. And really all that does is just puts you on our listserv, so you can kind of remain in the loop about what's going on. We seek a lot of input out from our members on what we should be doing in general direction. So make sure if that's something that you're interested in, please sign up there. Also, let us know how we can support you. It's just a brief survey. If there's a particular continuing dental education credit topic, different trainings or subject areas that you're interested in learning more about, we can help kind of facilitate that. So let us know about kind of more about what your interests are via that survey as well. Visit our webpage. Alex will also put that into the chat box for you to access. We have our on-demand webinars, our recordings available there. The Tribal Oral Health Services during COVID-19 that we partnered with we partnered with the National Indian Health Board, on that webinar, and heard from the absentee Shawnee tribe and the work that they are doing to mitigate the risks for COVID transmission in the dental offices. So that is available on our website. Also, the very first webinar in this series, which was Dental Therapy, the Basics, that's also available to watch on our webpage. We will get this also posted there probably within a week or so. Hopefully sooner. And then also you'll find other resources, one of which is the Oral Health Data Resource Guide, and there's a lot of information there that hopefully will be of use to you. So thank you again for all of those that attended. I appreciate your attention. And so to obtain the 1 hour of CDE credit, access this evaluation survey. And then once you complete the survey, you'll be redirected to the course attendance verification form to download for your records. There's also information on how to obtain CDE credit through the Indian Health Service if you are a tribe or tribal serving organization only. If you have any questions about CE or CDE or have any issues obtaining that, please feel free to reach out to me, and my email is listed below. Again, thank you all for your time and attention. Everyone take care, and we will see you all soon. Thank you to our presenters. Thank you so much, Dr. Bailey. Thank you, Roz.
So much. It's been a pleasure.
All right. Bye, guys. Take care, everyone.